Good afternoon, everybody. Thanks so much for joining the Lifespan Town Hall with an update on our COVID-19 vaccination program. I'm joined by a very distinguished panel of experts that I'll introduce in just a second, and I'll remind our panel of experts to please keep their microphones on mute until I call upon them. I know many of you are out on the front line still working very hard, taking care of all of our patients, both COVID-19 and non-COVID-19 alike. But yesterday, as you know, we vaccinated our very first healthcare worker here at Lifespan. I must say I was able to be in the room to witness it, and I got chills. I got chills watching what we all now hope is a glimmer of light at the end of a very long, dark tunnel. So there is hope. By the end of today, we think we will have vaccinated close to 500 of our workforce, and by the end of the week, close to 2,000. So help is on its way, and the light at the end of the tunnel is growing brighter. Lifespan is following the state and CDC guidelines for the prioritization with patient-facing healthcare workers who have direct contact with infected patients or infected patients' fluids getting the vaccination first. We received 2,000 doses of the Pfizer vaccine yesterday and are expecting another 1,000 doses today. So we hope to be able in this first round to immunize almost 3,000 people. We're also expecting 4,000 doses of the Moderna vaccine to arrive in the next week or so. As you know, the Pfizer vaccine requires 2 doses about 21 days apart, and the Moderna vaccine requires 2 doses about 28 days apart. We were able to begin vaccinating our highest risk providers and staff within hours of receiving both the vaccine and approval from the Rhode Island Department of Health. Today, and for the days to come, we're holding vaccination clinics at all 4 Lifespan hospitals at various times to accommodate all the schedules. The purpose of today's town hall is to share with you, number one, the prioritization for Lifespan's vaccine program, who gets it when, the science about the vaccine's safety and efficacy, address some concerns you may have heard about potential side effects from receiving the vaccine, and most importantly, hear from our key leaders across the organization about the importance of getting the vaccine and why they plan to get the vaccine or have already received the vaccine. The vaccine is not mandatory, but employees are strongly encouraged to get the vaccine to keep themselves, their family, and their patients safe. That's a recurring theme you're going to hear in the next hour, why we believe you should receive the vaccine. We're also going to leave some time at the end to answer questions. Questions were submitted in advance. We'll open the chat function. You'll be able to email me questions. Let me just run down the list of who we have on the panel today, and then we'll get started. So we have Dr. Karen Tashima, an infectious disease specialist from the Miriam Hospital, who served as a member of the statewide COVID-19 vaccination task force. Dr. Sabina Holland, a pediatrician, also in the Division of Pediatric Infectious Diseases, who also served as a member of the statewide COVID-19 vaccination task force. And Dr. Thomas Bledsoe, physician, Brown Physicians, also a member of the statewide COVID-19 physician task force. We have Christine Collins, our Vice President and Chief Pharmacy Officer at Lifespan. Dr. Mitchell Levy, Medical Director of the Medical Intensive Care Unit at Rhode Island Hospital. Dr. Len Ramel, Medical Director of Epidemiology and Infection Control at Rhode Island Hospital. Deb Coppola, Vice President and Associate Chief Nursing Officer at Rhode Island Hospital and Hasbro Children's Hospital. And Dr. Ken Wood, our Executive Vice President and Chief Clinical Officer. So let me start, Dr. Tashima, with you. Explain a little bit about the work of the state task force. Explain a little bit about the vaccine and the importance of getting the vaccine. Dr. Tashima?
Thank you. So I would like to start first with the task force. We were asked, about a dozen or more of us were asked to participate from the governor's office on this task force, and it was really, our mission was to look at the safety of any vaccine that's coming through and determine if this is something that Rhode Island should participate in, that we should recommend this for Rhode Island residents. So really looking at the safety as well as considerations of equity and how to prioritize our populations. I'll talk a little bit about the Pfizer vaccine that we are talking about so much today, and the Moderna vaccines. So the Pfizer vaccine was approved for use by the FDA, by the CDC, as well as the Advisory Committee on Immunization Practices. So we have information from that study. The study enrolled about 43,000 people, and about 20,000 people received the vaccine, 20,000 people received placebo. So we have a good amount of information. We know it's really, really effective at preventing getting sick with COVID. So we know it's about 95% effective, and then we also know that it's safe. We know the safety data from the couple of months that these participants have been in the study, and the study will continue for about 2 years. So there will be longer term safety data collected and published and given to us. So, but from what we know that it's important to know that the side effects are going to be happening for the first day to 3 days after getting the shot. A couple of people on this call today have gotten the shot yesterday or this morning, so they can tell us how they feel. But basically, it's really things that we would expect from a vaccine, a sore arm, but you may feel something more than that, along the lines of what we tell our patients about the Shingrix vaccine, that they may have, they could have a fever. You could have some muscle aches that are there for the day or two. You could feel fatigued or a headache, but that these side effects should go away pretty quickly. So we also know the Moderna vaccine is coming very soon, and we'll have access to that as well. Similarly, it's as effective at preventing COVID disease. So, but we're going to hear all of that information towards the end of this week. We're going to hear all the details about that vaccine, and also put that under consideration for us to administer here in Rhode Island. So I can end there, and I'm happy to take questions later.
Great, Dr. Tashima, thanks very much, and great job yesterday at the press event when we vaccinated our first healthcare worker. Dr. Bledsoe, same question to you. A little bit about the statewide task force and your perspectives on getting the vaccine. Dr. Bledsoe?
Yeah, the task force has been meeting since October. It was a different world pandemic-wise, especially in Rhode Island back in October, and certainly politically a different world at that time. The vaccine production and distribution poses tremendous logistical challenges, but also societal ethics challenges. How do you decide when a treatment is safe, and who gets the vaccine first, and what's the priority? So the committee has been is a broad representation. There's a pastor, there's a superintendent of schools, there are people that work with nursing homes and hospitals. One of the things that we really learned in that committee work over the last couple of months is about what the warp speedness entails. And the warp speedness is not about safety. And we really had some very solid information about the development process and the safety measures that were in place. So what the feds talk about with developing the vaccine and getting it out was eliminating the white space, doing all the normal check boxes for safety, but just making the whole process so much more efficient. And it's been quite incredible to see how this has rolled forward. The second thing that we learned is who gets sick in Rhode Island. There's tremendous disparity in socioeconomics and ethnicity and other factors. Applying the committee decided early on to apply that equity lens across the board with how the vaccine would be rolled out in Rhode Island. The feds make some recommendations to the CDC. The CDC makes recommendations to the state, but it's really at the state level that decides who gets vaccine in what order. So the last thing is that we've been thinking in terms of victims and vectors, in terms of who gets the vaccine when. So people most at risk, nursing home residents, and are among the most vulnerable. But who's at risk for being a vector? And that's where our lifespan community comes in. So we're trying to vaccinate the folks who are most at risk for being a vector, for inadvertently picking up the vaccine despite your care in your outside life and bringing it to work. So the committee voted on Monday to approve release, is convinced about the safety, and we're eager to get it into all of you and keep you safe, keep your family safe, and perhaps most importantly, keep our patients safe. Just by a final word, the question about altruism comes up with a limited supply of vaccine. Should I be altruistic and wait and get at the end of the line? Or is really that altruism move to get in the front of the line and get the vaccine as soon as possible to protect our patients? I think our take is that it's more altruistic to get in there and get your vaccine. Thanks.
Dr. Bledsoe, thank you. Terrific. The third lifespan physician that served on the task force is Dr. Sabina Holland. Dr. Holland, talk a little bit about the issue of vaccinating children and also the issue of ensuring that there's equity in the distribution of the vaccine. Dr. Holland?
Thank you. One of the most important priorities that the Rhode Island COVID-19 Vaccine Subcommittee and Lifespan's COVID-19 Vaccine Task Force had was to ensure that the vaccine was distributed equitably, beginning with those individuals at the highest risk of acquiring COVID-19, including those in healthcare settings, frontline workers, those that are residing in congregate care settings, and those high-risk individuals that are living in communities of color that have been disproportionately impacted by COVID-19. After reviewing recommendations from national organizations on equitable vaccine distribution, I can tell you that both committees spent significant time considering how to fairly distribute the vaccine across the state and here at Lifespan. In doing that, in considering the equitable distribution of vaccine, we have to consider children. Although children are much less likely than adults to have severe COVID-19 or to die, they have been seriously ill and they have died from COVID-19. Clinical trials should include children so that we can prevent their hospitalization and prevent rare but serious complications such as myocarditis or multi-system inflammatory syndrome, MIS-C, a hyperinflammatory response to coronavirus. Children of color are similarly disproportionately impacted by COVID-19 as adults. In fact, more than 75% of children who have died from COVID-19 have been minorities. The emergency use authorization for the current COVID-19 vaccine is approved for individuals 16 years of age and older, and clinical trials are ongoing, including children as young as 12. That being said, there are no studies right now including children less than 12. In closing, more studies that include children and the COVID-19 vaccine should be done so we can begin including them in our vaccination efforts, both to prevent the spread of disease and to protect those that are at highest risk.
Terrific. Thanks very much, Dr. Holland. Next up is Christine Collins, our Chief Pharmacy Officer. Christine has been absolutely at the center of the strategy to make sure that Lifespan is prepared as it can be to administer the vaccine literally within hours of receiving it, which we did yesterday. She's also become an overnight celebrity with her picture being splashed over the Providence Journal and the Boston Globe. She was the person who administered the first vaccine yesterday. Again, Christine, you've done just an extraordinary job over the last couple of months. Great to have you on the panel. If you don't mind, talk a little bit about how we are prioritizing who gets the vaccine and when among our Lifespan employees. Christine?
Thank you, Dr. Babineau. I will say for all the planning we did, that moment with that media shot was not planned. That was not the intent. But other than that, everything has been going along great. And it has really been my honor and privilege to be leading such an important program. Rolling this vaccine out across Lifespan is so important to our organization. And I'm just so proud to be part of this and to work with such an outstanding team that really pulled all of this together. So Lifespan has actually been planning for this for several months, actually since the summer. Our goal was to be ready to vaccinate the highest risk employees, as Dr. Babineau said, within hours of receiving the vaccine. And we did it. A lot of people had to work really hard to make this happen. but knowing that it was to protect our employees and our providers motivated us all to put in that extra effort. One of my most favorite questions that I'm asked, and I will say that I am asked this very frequently, is when can I get the vaccine? I love hearing that question because it means people want to get it, and that's great news for all of us, even including for our patients. Right now, we're focusing on employees and providers who have the highest of high risk of exposure. We understand that everyone has some level of risk, but it's important that we focus on those with the highest risk first. Then our plan is to quickly move to the moderate risk, then to lower risk. This plan, as Dr. Bledsoe had alluded to, was decided by a special subcommittee of the task force. We want to protect everyone starting on day one, but we don't have enough vaccine to do that just yet. So we pulled together experts in areas such as vaccines, ethics, medicine, employee health, nursing, pharmacy, infection prevention, lawyers, communications to help us with this prioritization. They used an approach that was based solely on a person's potential for exposure. This made the process fair and helped us vaccinate the highest of high-risk employees and providers first. But the other groups are not far behind. In fact, we hope to start vaccinating our moderate risk group sometime next week or the week after. It will all depend on the supply of vaccine that we have, but we're going to keep vaccinating as quickly as our vaccine supply comes in. As Dr. Babineau mentioned, to make things convenient for everyone, each hospital has set up its own vaccination center. And vaccine clinics are being held at different times throughout the day to accommodate all shifts. Getting the vaccine is completely voluntary, but we hope you will choose to do so. I know that when it's my time and it's offered to me, I will be getting it. And I want to just take a moment before I close to thank all of the members of the task force, especially Shannon Baker, Martha Roberts, and Kelly Sullivan, who coordinated much of this work, and of course, the great partnership with Jackie Perillo and the employees on the employee health team, and all of the subcommittee members that worked so incredibly hard to bring all of these challenges, get through all of the challenges and bring all of these elements together. We keep saying this is not your average flu vaccine clinic. This one took a whole community. Thank you.
Christine, thank you. That was terrific. We really do have a world-class pharmacy here at Lifespan, and thank you for leading it. You do an amazing job. Next is Dr. Mitchell Levy. Dr. Levy has been in the eye of the hurricane going back to February when we admitted our first patient. 24/7, 365 applies to both him and Dr. Mermel. Mitch, what are you hearing about concerns about the vaccine? And I believe you were one of the first to get it yesterday, so I'm curious how you're feeling. Dr. Levy?
Thanks, Tim. Right, so the two questions I get asked most frequently are, am I going to take the vaccine, and is it safe? So the first answer is easy. I did, I will, I took it yesterday, and actually I'm feeling quite fine today. I'm not feeling any of the reported side effects of fever or muscle ache, so I'm really happy that I took it. The second question of is it safe, as you heard Dr. Toshima say, the trial involved over 40,000 patients. It was a well done randomized controlled trial. I really believe that this is safe as any vaccine that's been produced. The side effects that are most commonly reported are fever and muscle aches, and there have been no other serious reported side effects except some allergic reactions. But I believe that over the 5 or 6 months that this trial was conducted, the results really demonstrate the safety of this. I think the biggest challenge is that we read things on the internet that just simply aren't true, and it affects our concern and ability and willingness to take the vaccine. So I would say to every employee out there, please stop reading the internet about the safety. There are a lot of true reports that you can get from any of your managers or anywhere about the facts about the vaccine and the trials that tested the vaccine, and please consider getting the vaccine. Thank you.
Dr. Levy, thank you. And again, thanks for everything you've done and will continue to do in this pandemic. Another doctor that's been in the eye of the hurricane is Dr. Len Mermel, been with us since the very first patient, again, admitted. Len, talk a little bit about the science of the vaccine. In particular, how soon after being vaccinated are you immune? And once you've received the vaccine, either the first or the second dose, do you still need to practice infection control precautions such as mask and gowning and that sort of thing? Dr. Ramel?
Thanks, Tim. So regarding immunity, it's important to know that full immunity won't take place until at least a week or so after the second dose. There's some immunity based on some of the data after 14 days after the first dose. You're still at risk, need to get the second dose for full immunity, and sometime thereafter, the full strength of our immune system will kick in to abort any potential infections. So you certainly can't let your guard down. I'll come back to that in a couple of minutes after the first dose or even after the second dose. But stepping back for a minute, back to the vaccine safety, I think it's very, very important. A question that I'm asked is, can I get COVID from the shot, from the vaccine? And it's very, very important for everybody to realize that the Pfizer and Moderna vaccines do not contain any virus. There's no SARS-CoV-2, which is the virus that causes COVID, in the vaccine. You cannot get COVID from the vaccine. So dispel that myth, that concern that you may have. How do we prevent COVID from spreading in our community? Well, ultimately, we need about 70% or so of everybody in Rhode Island either to have been infected from somebody else or to have been vaccinated. Despite the large number of cases we have to date in Rhode Island, we're thankfully nowhere near 70% of individuals already infected with COVID. So you need to be vaccinated to get us up to what we call herd immunity, to protect yourself, your loved ones, and your contacts. So it's very important doing this for you, but everybody around you. With regards to infection control precautions, so the vaccine is about 95% effective sometime after the second dose, but you really can't let your guard down anywhere along the line before or after vaccination. We still need to use masking, social distancing, hand hygiene, because there's a possibility. We're not certain if the virus could potentially, someone coughs in your face who's infected with COVID after you've been vaccinated. It's at least theoretically possible that the virus could be, let's say, in your nose and throat. You yourself wouldn't get sick, but there's a potential, at least theoretically, that you could spread that to someone else. So even after vaccination, certainly until we have herd immunity, you're going to need to continue to mask, social distance, hand hygiene, and use the similar precautions you've been using all along. So that's my final comment. Thanks for your time and attention.
Great, Dr. Ramel. I'm sure we'll be back to you with questions. Deb Capola, you're out and about walking the halls of Rhode Island Hospital. You're checking in with our frontline workers, checking in with our nursing staff. What are you hearing? What are the questions? What are the concerns? What are people asking you? Just what are you hearing out there on the floors of our hospitals? Deb?
Thank you, Dr. Babineau. In speaking with our nurses over the last couple of days, I've been hearing from some individuals who are not planning on receiving the vaccine for various reasons, some related to science, some related to just personal opinion. But I want to take a few moments to highlight the impact of this decision, encourage all of our staff to consider its importance. We've all heard the airline analogy: when there's trouble, secure your own oxygen mask first before helping others. And I think we as caregivers and healers are also leaders, and we need to others look to us and depend on us, not only for our care, but for our guidance, and take us as examples. So we must take the lead for ourselves, or we will not have the capacity to care for our patients. From a personal perspective, I'm not on the front lines as many of the people that I talk to are, but I do feel the importance of keeping myself healthy for our mission here at the hospital, for my family, for my community. On a personal level, I have a 90-year-old mom. I haven't seen her in months. I'm not going to spend Christmas with her. She's been isolated for a long time, and I think we all have our personal stories that impact us and that affect our decision making. And I would ask that everyone think about your story and what's impacting your decision. So I just want to encourage people to please participate in this time of healing. Get your vaccine, be here for our patients, get reunited with your families and friends. I want to say a thank you to everyone that has done incredible work over the past year. And in conclusion, just be well, be safe, and get your vaccine.
Deb, thanks very much. Appreciate those comments. Our final panelists, and then we'll open it up to Q&A, and I'm gratified to see there are already a number of questions coming in. So I encourage you, go to the Q&A function, submit a question. We'll try to get to as many of them as we can. Dr. Ken Wood, you're charged as the Chief Clinical Officer with helping keep the entire lifespan clinical operations moving, flowing, taking care of patients, making sure we have capacity. Talk a little bit about that and how the vaccine is a critical strategic element in our ability to basically stay open for business. Ken?
Yeah, Dr. Babineau, thanks so much. And to those that are on the task force, the panel, and Christine Collins and her group, just a deep sense of appreciation for an extraordinary job. So I would frame where we are today and compare and contrast where Surge 2 is compared to Surge 1. In the current surge, it appears we probably have a higher degree of prevalence in the community, which has similarly affected our employees as well, which is a pivotal point as we look at our mission to provide care. At the same time, it's more dominated by non-critical illness, non-ICU patients, and that's created challenges with patient flow and throughput. And particularly in contrast to Surge 1, where there was a pause nationally in care, a virtual moratorium on some aspects of care, and this was to the detriment of many patients with cardiovascular disease or oncologic patients nationally because hospitals had shut down. So lessons learned, we continue to provide care in all aspects of disease. So you can, I think, look at the numbers and see the incremental prevalence in the community, the number of COVID patients that we're taking care of, even to the point where we've opened up an alternative hospital. And the same prevalence is in our staff. So those challenges really of providing the care that we need to provide to COVID and non-COVID patients, I think for any that are involved in looking at our staffing models and patient flow, realizes how incredibly difficult that this can be. So I would say there is no better time that the vaccine could have come about. This is an absolute imperative for us. And as Dr. Mermel implied, we need to have herd immunity, which means probably 70 to 80% of the population needs to be immune before the virus hopefully withers away and doesn't have the opportunity to infect people. So the way to do that is the vaccine. Allowing folks to get infected and assuming we'll have enough infected people will never get rid of the virus. The vaccine really is the answer, and I think this is one of the most important and most imperative things that we can do is to get the vaccination, become immune, and as a consequence, we can have the virus hopefully over the period of a several month time window as we get everyone immunized. This will not be any continuation of Surge 2, but the vaccine's absolutely imperative. So Dr. Babineau, thank you.
Dr. Wood, thank you. Thank you for your leadership during this pandemic. All right, I'm going to start opening it up to questions. We have several, which is terrific. And as I said, we'll try to get to most of them. Dr. Tashima, this question is for you, and a couple of folks have asked it. Part of the reason why folks may be reluctant to take the vaccine is they don't understand how it works. In the simplest, and I mean simplest, of all terms, like so that I can understand it, how does the vaccine work? I think if we can help explain how it works, we may get more people to take. So a tough challenge, I know, because I've seen all the diagrams and all the arrows and the mRNA, and I think I understand it, but please try to explain it to me so I do understand it.
So basically, the Moderna and the Pfizer vaccines work in similar ways. They're made out of mRNA, messenger RNA, and this messenger RNA is packaged in a lipid case, so that because the messenger RNA is very fragile, it'll disappear on your desk within seconds. So it has to be stable enough to get into our cells and do its job. So this messenger RNA codes for a protein, the spike protein that we've heard a lot about. That's the protein that is really important for the virus to get into our cells. So we get the shot, the messenger RNA makes some protein, and then our bodies see that protein and our immune system responds to that. And what that does then is it will we will start to make antibodies. We'll start to have cells that can recognize the virus by virtue of knowing what that spike protein looks like. So, but what happens with the messenger RNA that we were injected with, that disappears within a few days. So the vaccine is not going to be hanging around in your body for any longer than that. What's going to be hanging around is your own immune system's memory that it saw this, and it's going to be ready to take care of the virus when it sees it. Hope that was sufficient.
Great job. Thank you. I do understand, but I'm going to keep you on the hot seat for a moment here because there's a follow-up question. So RNA, DNA, is this messing with our DNA? Are we getting into people's genetic codes and somehow changing the genetic code? RNA sounds like something scary to put in my body.
So the RNA is not going to get put into our own DNA. It doesn't work that way. It's a one-way street out to the protein. So it will not get converted into DNA. There are some new vaccines that are coming along. As you know, there are at least 4 other vaccine candidates. And so we want to pay attention to what's coming down the road. AstraZeneca and Janssen are DNA-based vaccines, but they won't multiply in our bodies. So, so we can discuss that further in the future.
Great, thank you very much. Christine Collins, several questions, and I'll close with some of this, but back to you. How do our employees sign up? And managers want to know how they can know that their employees have signed up in terms of just trying to predict staffing so that if someone does have a side effect, they can plan for that, or is that kind of protected under HIPAA, that if a person is going to get vaccinated, that's private information and the manager really can't know that. So how do we sign up? Where do they go? And managers want to know how to get a feel for who on their floor may be signing up. Christine?
So sure, right now, the individuals that are invited to sign up are those, again, at the highest of high risk. The managers have been notified. If you are a manager and you haven't received a notification and you've reviewed the prioritization criteria, then let us know because we want to get that resolved quickly. But the managers should have been notified, and they in turn should have been able to notify their employees in those highest of risk categories, and then send them the information that they need to be able to schedule their own appointments. So they're doing self-scheduling. However, we're asking each manager to support that because we want to make sure not everybody is scheduling themselves on the same day. As you can imagine, if everyone has some of these unpleasant side effects that are unpleasant enough that they can't come to work the next day, then that would be a problem. So we're asking managers to really stagger their employees in certain areas so that not everybody is at risk for having those unpleasant side effects and not being able to come in the next day. And then the employees would just schedule themselves based on that. As far as rolling out to the moderate group, again, we hope to do that next week. We'll be reaching out to managers who have employees that fall into that moderate category, and they will follow a similar process as far as sending the email that allows for the scheduling out to those employees and working with them to stagger those appointments as much as necessary. And then from there, we move on to the lower risk.
Great, Christine, thank you very much. I'll say more about that towards the end. Dr. Mermel, we hear that the first dose goes fine, but most of the side effects happen at the second dose, both with Moderna and Pfizer vaccines. A, is that true? What are those side effects? Are they serious? And what percentage of people who are getting the second dose will have some type of side effect? Dr. Mermel?
Sure, and Dr. Tashima or Holland or others can certainly chime in. There does appear to be a greater preponderance of side effects after the second dose, but as has already been said, it's important for our staff to realize that in general, the side effects are mild. You heard Dr. Levy was vaccinated yesterday. He looks great as usual and is here at work, working full time. So people may have like a flu-like, they may have feel a little feverish, they may have a little headache, they may have some muscle aches. That is so to be expected in as many as maybe half of those receiving the vaccine, maybe more so again with the second dose. But it is very important to realize a side effect of the vaccine should not involve respiratory symptoms. If you start coughing, now suddenly you have a runny nose, lost a sense of smell, that's not from the vaccine. So the vaccine will not cause respiratory symptoms or loss of smell, but may cause, again, some muscle ache, joint pains, headache, fatigue. So that's, that's basically it.
Thanks, Dr. Mermel. Dr. Holland, anything you want to add, particularly side effects in children? I'm going to lump a bunch of questions on you. Children, pregnant women, or women who are breastfeeding, issues related to the vaccine. Dr. Holland?
Thank you. I think that one thing to know is that there's no data in pregnant or breastfeeding women. There's no data in children less than 16 years of age, and even the data that is in those that are 16 years and older is limited. And so really what we've wanted to do from the perspective of the pediatricians, and I know my primary care and OBGYN colleagues have wanted to not exclude those healthcare workers or those high-risk individuals who may be pregnant or breastfeeding or are pregnant, but we really encourage them to reach out to their healthcare provider to talk about their risk, the risks that are in the communities for acquiring COVID-19, and what the implications of having a vaccine that doesn't have any data. I will say that the vaccine is, as Dr. Tashima mentioned, it's an mRNA vaccine. It degrades very quickly. Our experts nationally and within Rhode Island do not believe that there will be adverse events. And at the state level, we don't believe pregnant women and breastfeeding women should be excluded, but we do encourage them to talk about it with their healthcare provider.
Great, thank you. Dr. Bledsoe, this is great. We're happy that we're vaccinating our frontline lifespan healthcare workers first. Two-part question. One, when do you think it will be available to the general public? Our neighbors, our friends, the folks who are calling us saying, when can I get my vaccine? And number two, we're already hearing stories 24 hours into this of a black market where people can buy their way to the front of the line. Any truth to that rumor? So two-part question, Dr. Bledsoe.
So when can I get it? As Christine said, it's a great question to hear because that signifies a degree of confidence in the process. There's about 1 million people more or less in Rhode Island, and it's going to take a while to get all those vaccines out. Probably our committee is thinking in terms of 4 phases. Phase 1A is who you heard about today, high-risk healthcare workers and nursing home residents and staff. 1B is those with serious medical problems at risk for significant complications of the coronavirus. C is people with other medical problems, people who live in congregate housing and essential workers. And then we work our way out to others with medical problems, and then everyone else is in phase 4. So if your question is, I'm in phase 4, I'm not at increased risk, when can I get it? Probably summer or fall, maybe. I'm not an expert on that one, but that would be my guess. Part of the reason to get one is if you can't control your environment, and folks who are relatively frail but can stay safe, probably the best strategy for now is to stay safe and let those who can't control their environment or at higher risk get it first. I haven't heard about the black market. That's probably predictable given the state of the world, but certainly the state will be sanctioning specific delivery sites. We're starting out with the hospitals just because they were set up for logistics and again, the highest risk workers. So probably there will be some certification process for the sites.
Tom, thank you. Deb, question for you. With the flu vaccine, if the employees don't take it, they wear a mask. All of our employees are already wearing masks. So again, what's the motivation for them to get vaccinated if they're going to be wearing a mask at work anyway? What would you say to the folks who say, look, I've already got a mask on, why bother? Deb?
For all the reasons I think we talked about today, is that just because you're wearing a mask doesn't mean that you're not subjected to being infected. We're trying to keep our patients safe. You may be exposed in the community. You may be exposed from a patient that is tested negative. We've had many instances where patients have tested negative on arrival and then convert to positive. So that sense of security should not, we're always at risk. We are always at risk, and until we get to the point where we have the herd immunity that's been discussed today, I think we all need to be cautious and take every caution. We don't know where it lurks. So yes, we should stay masked. We should keep our social distancing. We should stay away from each other in break rooms, as well as in the community and with our families.
Thank you. Dr. Levy, three-part question. Can you get the vaccine once you've tested positive for COVID and have symptoms? 2, does the vaccine work if you're sick? Is it worth giving it to patients who are in the hospital? And then 3, just a quick update on the latest treatments we're using in the fight against this pandemic. So three-part question, Mitchell.
Okay, the first question, which is it worth getting the vaccine if I've already had COVID? The answer is yes. The CDC has made it very clear. Remember, the vaccine is 95% effective. So there are a certain percentage of people who don't make antibodies even though they've had COVID. So those people remain vulnerable to reinfection, and there have been several reported cases of reinfection in the literature, and we never know who that is that didn't mount an antibody response to getting COVID. So the current recommendation from the CDC is for people, even if they've had COVID in the past, to get the vaccine. As far as the second, I don't believe, and I'd actually have to defer to Dr. Tashima or Dr. Mermel on this. I certainly don't know whether giving the vaccine would make someone worse if they were already sick. I'm fairly certain that there would be no benefit from the vaccine. And then I'll answer the third question before I turn it back over to Dr. Tashima or Dr. Mermel. We're still somewhat frustrated in our search for effective therapies. As most of you know, dexamethasone is really one of the only agents that have been convincingly shown to improve survival and improve clinical outcomes in patients with COVID-19. Remdesivir, unfortunately, there are now mixed results in the literature and mixed recommendations in the literature. And there are a monoclonal antibody that is primarily for patients before they get to the hospital, before they get sick enough, that is being tentatively recommended. But I must say that there really are yet to be any convincing trials that demonstrate a therapeutic power of interventions. In fact, I would say that the most convincing trial is in fact the vaccine trial. More than 40,000 patients, 95% efficacy. So in our search for effectiveness, we found that the most effective so far is actually the vaccine.
Dr. Levy, thank you. Dr. Tashima, anything you want to add to the question of if I start to get symptoms of COVID, I test positive with COVID, can I get the vaccine? Should I get the vaccine? Will the vaccine help at that point?
Sure. So This was not tested in the clinical trials. So if somebody was sick with COVID-like symptoms, they were not entered into the study at that time. So we don't know the information about that. The CDC did recommend that if you are sick with COVID, not to get the vaccine until after you're over that. So they don't want people with active infection coming into the healthcare setting to get the vaccine. So we don't know the answer entirely, but right now the recommendation is not to give it in the middle of a COVID illness.
Great, thank you. Dr. Wood, a little variation on the theme, just a bit off center for the vaccine, but update on where we are with testing patients having to test negative to go to a nursing home. What is our testing capabilities? What are our PPE capabilities? We've got a couple of tough months ahead despite the great news of the vaccine. Are we prepared from a testing standpoint? Are we prepared from a PPE standpoint? And right now, what's the testing policy for our patients both coming into the hospital and leaving the hospital? Again, another three-part question, Dr. Wood.
Yes, I would say we are, like every other virtual hospital in the country, competing for scarce resources. And I think the folks, Kim Halley and her team doing PPE, Ms. McAllister, Dr. Anthony with the laboratory are as vigilant and attentive to ensuring that we have the best supplies that we can. So they have full-time people dedicated exclusively to ensuring that we have PPE. We've gone probably on January 1, we'll go to a all front-facing personnel will be at a 95 level of masking, whether it's an ENVO or an elastomeric or N95. So we're doing the fit testing right now. That's gone, I think, extraordinarily well, just given the magnitude of people that have to be fit tested. So supply issues, but we've purchased an enormous number of elastomeric masks and ENVOs, so I think we should be okay. The testing is a very fluid and dynamic availability model right now. I think we're pretty static. It hasn't decayed significantly. As many know, over the last 2 to 3 weeks, we had to make revisions into our testing. So right now, the rapid test is in short order, so we're reserving that for patients that are admitted to the hospital, and particularly as we look at a screen for patients coming in, we've evolved to look at antigen test, and then if that has positivity, it's confirmed. So Dr. Ramel, the infection prevention team, has been really on top of that, and we've made alterations based upon the supply. But right now, I think we're in as good a shape as we can be. The other question was,
testing of patients coming and going. Are we testing patients when they're admitted and leaving?
Yeah, we're testing patients when they come into the hospital, and we're doing studies to make sure that we obviously put patients who are symptomatic into an appropriate arena. The asymptomatic population, we also are testing, but it's a turnaround time is a little bit longer, which is, again, when we have a limited number of tests. For the outgoing patients, there's been extensive discussions with the skilled nursing facilities and nursing homes, and Dr. Mermel has really been on point with that, has developed an algorithm that we're beginning to implement, working with the skilled facilities, realizing that they have their challenges with a very vulnerable population, and their points are well taken, but we're working with them because our ability to get patients out of the hospital is predicated on their ability to accept patients.
Great, thanks, Ken. Christine, I'll start with you on this one. A fair number of questions about, I'm a lifespan employee, but I'm not quote unquote high risk. I work in an office or I'm not at the bedside. Do I fall into the general public category and I'll get my vaccine with everybody else? Or because I have some relation to healthcare, will we be vaccinating a lifespan employee before the general population? Christine?
So our goal here at Lifespan is to vaccinate all of our employees and all of our community partners, providers that work here at our hospitals and healthcare settings. At this time, we don't know exactly how many doses we're getting, and that's really the limitation to all of this. Our goal remains the same, and we will be moving those vaccines out into people's arms as quickly as we can, working through the prioritization grid in a very methodical way. But it's all relative to the number of doses that we do get. But our goal is still absolutely to get to all of our employees.
Great, thank you very much. Dr. Holland, I'll start with you on this one. How long does the vaccine last? Is this going to be like the flu where every year I'm going to need to get a new COVID-19 vaccine? Dr. Holland?
Thank you, Dr. Babineau. So, I think the short answer is we don't know. It's such a new vaccine that there's, the data that was submitted to the FDA was 2+ months, looking largely at safety. And so I think what will happen is we will have many more people vaccinated. They'll do follow-up studies looking at the long-lasting, immunogenicity of the vaccine, and we'll be able to know. And then I will definitely punt to Dr. Tashima, who is much more knowledgeable on this subject than I am. Great, Dr. Tashima, how long are you protected, and will you have to get it every year?
We don't know right now, but we hope to know in the future. So the people who are in the Pfizer and Moderna studies are going to be followed for 2 years. So people who haven't gotten COVID and got vaccinated, they'll be followed and to see whether they get COVID over those 2 years. And the people who were in the placebo arm, they will be offered the vaccine as appropriate. So everybody will get the vaccine in short order.
Great, thank you. Dr. Mermel, would you like to add to this?
Sure. There's some data in the literature that I think was the Moderna vaccine. There were high levels of antibody protection, I think 3 months out. We had published some work showing that other coronaviruses, human coronaviruses, follow a seasonal pattern, and there's been other investigators that have shown the same, with obviously a winter predominance as with other respiratory viruses. So it wouldn't be surprising if even after we have some herd immunity that we don't know, 1, 2, or 3 years later, need to get vaccinated again, booster dose, possibly similar to what occurs with flu. The intervals we don't know, but yeah, I agree with everything that's been said. But there's some published data 3 months out, and I don't see any reason why we won't have more prolonged protective immunity. But that's just an opinion.
And an important opinion coming from you, Dr. Mermel. So thank you for that. I'm going to, Christine, I'm going to end with the formal questions. Then I'm going to ask my panelists if there's anything I forgot to ask, anything you would like to mention, raise your hand. I can see you on the screen and I'll call on you before we wrap up. Christine, if I get my first dose of either the Pfizer or Moderna, will someone call me to remind me to come back in 21 days or 28 days? What if I forget? What if it's 24 days and I was supposed to get the dose in 21 days? How are we going to handle the logistics of the second dosing? Christine?
We're not even leaving it to you to figure that out. We're going to do that for you. You will not even leave the building till you have that appointment for your second dose. So we're doing that on your way out the door before you even leave. Make sure you have that appointment so it'll all be scheduled. We will send you a reminder. We will run reports to make sure you did follow up, you did get that second dose. So it's very important for everyone to get that second dose. That's how you achieve those high levels of efficacy. So we will do everything that we can to make sure you do that.
Great, thank you. I lied. I have one more question, but I'm the moderator, so I can do that. Dr. Tashima, last question for you. There are a number of questions. Everybody has allergies. I have allergies. You have allergies. Which allergies matter? Hay fever? Allergic to shellfish? How do I know if my allergy is significant enough that I shouldn't get the vaccine? Dr. Tashima?
So in the clinical trial, they did not see any severe allergic reactions. So that's important to know. It was only after they started giving the vaccine, the Pfizer vaccine in the UK, they had 2 people who had a severe allergic reaction, and they were known to have severe allergies in the past. So the CDC recommendation is that the only people that should absolutely not get the vaccine are people who had an allergic reaction to the first dose. So we won't know that until you get the first dose. or if you've had a severe allergic reaction to an intravenous medication that could, and they think it could be related to something called PEG, that can be in some, could be in some of those medications. So if you carry an EpiPen, you can still get vaccinated. If you will be monitored for a longer period of time. I believe it's up to an hour or 30 minutes to an hour past the 15 minutes that is recommended for everyone. And we are fortunate to be in a healthcare setting so that if something were to really happen, there would be a ready response to deal with it. But food allergies, seasonal allergies, even some drug allergies are not contraindications to getting the vaccine.
Great, thank you. Final question, Christine Collins. I heard CVS will be giving the vaccine. Should I try to sign up at CVS if I'm not going to get vaccinated here? What role will CVS play in vaccinating healthcare workers, non-healthcare workers, and do you know when they will start administering the vaccine, Christine?
So anything you're hearing right now about CVS administering the vaccine has to do with their federal partnership. The federal government has partnered with retail pharmacies, not just CVS, but also Walgreens, Rite Aid, and several others to assist with the vaccination of nursing home and long-term care facilities, both the patients there as well as the staff there. So if you think about it in a hospital, we have the perfect setting to be able to muster up these vaccination clinics. Out in the community, out in a long-term facility, they don't have that ability. So the federal government wants to help them, and by doing that, they have partnered with these retail pharmacies to do so.
Great, thank you. All right, I want to thank our distinguished panel. As always, I learn something on these town halls, so thank you very much for your time. Thank everybody for tuning in. Thank you for everything you're continuing to do. I know it's been a long, hard battle. We've been at this since February. But I truly believe, and I think you heard today, the light at the end of the tunnel is finally beginning to shine. So thank you. I wish you a very peaceful and safe and joyous holiday season. And you know what the best holiday present to get is? A vaccine. You're right. Have a nice holiday season and tune back in. We'll do these periodically as we have other updates to share with you. Have a good afternoon. Thank you.